community, which is known as Mubahith. So this platform is there to connect researchers and professionals, and there's a gap between them. So we want to provide this platform so they can accelerate their progress. So join us to stay updated if this is your first time, or otherwise as well to share knowledge and move science forward. So our guest speaker today is Dr. Susanna. She's a consultant plastic and oncoplastic breast surgeon. She's currently practicing at Sheffield Teaching Hospital, NHS Foundation Trust. She specialized in plastic and reconstructive surgery from University of Genoa, Italy. She has done several advanced trainings in Italy, UK, and also her fellowship from China. She is BRESO certified and assistant professor at University of Nottingham. She's part of these research institutions that is mentioned here. Her major area of expertise is into the breast reconstruction. She's into pectoral implant-based techniques, chest wall perforator flaps, and microsurgical reconstruction. Her achievements are so many, but there's limited that I can mention here in this platform. So she is a part of, she has like 20 plus reviewed publications. She is international educator and mentor, and we welcome her here to be a part of our platform and share her knowledge with this community so we can learn from her, and let's see what she has to share. Welcome, Susanna. Over to you.
Thank you so much for the kind introduction. I'm really honored and grateful to be invited by you, and I'm really happy to join you today. Let me try and share my presentation. Okay. Oh, can you see it?
Yeah.
Amazing. So my talk today is about a brief introduction on oncoplastic breast surgery. We know that the background on breast cancer is that breast cancer still represents the most common female cancer, and it is the leading cause of female cancer-related deaths. It accounts up to 1.7 million cases worldwide, and 0.7 of that cases affect the male population. 5% of breast cancer is inheritable, but at the same time, we're seeing an increase of its incidence and a decrease of its mortality. And that is thanks to the advancement of the screening techniques and also of the chemotherapy, radiotherapy, and those all the adjuvant and neoadjuvant treatments. And as you can see on the right-hand side, on average, 1 on 8 patients are affected by breast cancer or in their lifetime. Breast cancer can present in several different presentations. The most common is a breast lump, but we do also have nipple discharge, nipple inversion, skin changes, axillary enlarged lymph nodes, breast or arm lymphedema, and last but not least, we have screen-detected breast cancer. And that is why the one-stop clinic is really important. That is where we assess our patient with the triple assessment. We start with the clinical evaluation, we take patient history and we examine them. Then our radiologists start and perform ultrasound scan and mammogram, and they proceed when there is a suspicious breast lesion with a core biopsy to obtain a tissue diagnosis. We have also clinical assessment for our breast lesions that goes from P1 to P5, from normal breast tissue to malignant. And as you can see here, there is a standardized way to perform a breast clinical assessment. And we should also not forget that when we have any suspect of breast cancer, we have to assess our patient for potential metastasis sites. We have to palpate the spine, perform abdominal palpation, and also lung auscultation. Breast cancer staging is important before the surgery to guide our decision making, and also after the surgery to guide our following treatments. And there is a stage distribution of breast cancer at presentation that is different when we have different regions and countries. As you can see here in Europe, there is mainly early breast cancer, which means stage 1 and 2. It accounts up to 60% of our patients. Whereas, for example, in Pakistan, the average cases is quite well divided between stage 1 and 2 and local advanced breast cancer, which is a stage 3 cancer. And that is why we have to raise public awareness, because this is also key to proceed with our surgical planning and to following treatments. Neoadjuvant chemotherapy is also important to increase our, to improve our operability and to increase up to 1/3 of patients to breast conserving surgery. We have to remember that any patient who is a candidate for adjuvant systemic treatment can be considered for neoadjuvant chemotherapy, which means chemotherapy before the surgery. Moreover, these treatments establish tumor sensitivity to chemo and can guide subsequent drug selection and treatment. We have to remember that complete pathological response can be achieved in up to 90% of HER2 positive and triple negative breast cancer. So that's another arrow that we can use for our patients. Our surgical decision-making has quite improved during the time. We started with halsted radical mastectomy when we had to remove all the breast tissue, the pec major and minor, and also perform a complete axillary clearance. But nowadays we have plenty of possibilities. And that is when our oncoplastic possibility comes into place. As you can see here, we started in 1882 with halsted radical mastectomy. Then we passed through modified radical mastectomy when we could preserve the pec major and minor muscles. And finally, with the advent of lumpectomy, breast conserving surgery, and the possibility of perform breast reconstruction, we can offer to our patients satisfying aesthetic and still oncological radical results. Here we can see the rationale of breast conserving surgery, that is thanks to Bernard Fisher with the NSABP trial, which proved that breast conserving surgery plus postoperative radiotherapy is as effective as mastectomy in terms of overall survival, disease-free survival, and distant disease-free survival. And moreover, since breast cancer is clearly a systemic disease, the possibility of performing neoadjuvant chemotherapy comes into place. And we could switch from total mastectomy as one size fits all to breast conserving surgery and tailored treatments for our patients. Going to our main topic, what is oncoplastic breast surgery? This is the combination of oncological breast cancer surgery with plastic and reconstructive techniques to achieve optimal cancer control and preserving or even improving cosmetic outcomes. And that is what we have to aim nowadays for our breast cancer patients. After we have a breast cancer diagnosis, as surgeons, we have clearly to consider all patient comorbidities, medication, BMI, smoking habit, previous radiotherapy or previous breast surgery, breast size and shapes, and then we have to balance two options mainly, breast conserving surgery or mastectomy. The patient on her side, she has to consider her occupation, expectation, hobbies, lifestyle, recovery time, and so much more clearly. That leads us to the shared decision-making process, which is really important in breast oncoplastic decision-making. There are several factors that influence the treatment decision in breast surgery. Some of these are breast cancer related, such as histology, tumor size, multifocality or multicentricity, biology and cancer stage, and some others are patient related. First of all, patient choice, which is really important in our process. And then we have patient age, comorbidities, gene mutation, and also pregnancy. Here you can see a simple diagram that is the start of our decision-making process. First, we have to see if we can perform breast-conserving surgery and if the patient can have radiotherapy. If yes, we have to discuss breast-conserving surgery and all the possible oncoplastic technique that can be associated with that. If the patient cannot have breast-conserving surgery or she cannot have radiotherapy, then we have to consider mastectomy and reconstruction. As you can see here, there are 3 levels of oncoplastic breast surgery. Level 1, when less than 20% breast volume has to be excised, and that's when we use tissue displacement techniques, also called therapeutic mammoplastics. Level 2, when we have to remove up to 50% of breast volume, and that's when we use a tissue replacement technique, also called chest wall perforator flaps. And level 3 is when we have to perform a mastectomy and reconstruction. As you can see on the top of this slide, when we increase the cup size and the ptosis, we swiftly go from chest wall perforator flaps to therapeutic mammoplasty. And there is an area in the middle in which both options are suitable for the patient. And clearly, you know, the real world is different. More than one option is suitable for our patients. And we have also to discuss different options with the lady always. The road to our success starts with a good surgical planning and carries on with a perfect surgical technique. And it is concluded with complication, prevention, and management. And that's what we are going to discuss now. I would like to start discussing breast-conserving surgery, which is really important because more than 80% of our patients diagnosed with breast cancer are going to have surgery. And we know nowadays that about 60% of them can have breast-conserving surgery. This is also called lumpectomy or wide local excision, and the meaning is to resect breast cancer from skin to muscle, not included, with a rim of healthy tissue around it, which is called the margin, preserving as much healthy breast tissue and shape as possible. We can face palpable or non-palpable lesion, and when we have a non-palpable breast cancer, we can insert a metal wire or even better a marker inserted by the radiology team that helps us as surgeon to identify the area to remove. We call it a simple wide local excision when we just remove the cancer and we approximate the rest of the tissue layer by layer. There are some contraindications to breast-conserving surgery, such as inflammatory breast cancer, contraindication to radiotherapy, such as previous radiotherapy, collagen or vascular disease, and restriction of arm movement. There are some relative contraindications, such as multicentric disease, multifocal disease, and unfavorable tumor to breast volume ratio. And that is when we have to consider oncoplastic breast surgery. Here you can see some example of breast-conserving surgery. We can have a skin incision on the top of the breast cancer. We usually aim for aesthetic skin incision, which can be in the inframammary fold, in the lateral mammary fold, or periareolar. And we have also to remember that a simple wide local excision sometimes leads to very unsatisfactory aesthetic results. and these results are usually worsened by postoperative radiotherapy. Here you can see some of them, and these patients would have been better served with therapeutic mammoplasty, with chest wall perforator flaps, and that is why we have to keep these techniques in mind when we first see our ladies. Speaking of which, therapeutic mammoplasty. Therapeutic mammoplasty is a volume displacement technique. We combine lumpectomy with breast reduction or breast uplift, which are techniques borrowed by plastic surgery. These aim to allow an oncologically safe cancer removal and breast reshaping, and this leads to an improvement of cosmetic outcomes, especially in moderate to large-breasted women. We can apply this technique in low tumor to breast volume ratio, medium large volume breasts, and breast ptosis. This technique enables us for wide excisions and clear margins, and this reduces our re-excision rates. The outcomes are better, clearly, compared to mastectomies. There is no donor side morbidity, and we have to keep in mind that usually this is a bilateral surgery for symmetry. And you can see on the left-hand side how many techniques we do have for different cancer locations. Why we are so keen on therapeutic mammoplasty? Because this is a valid alternative to mastectomy. There are several papers published on that. I just want to cite one of these published from the eyebrow steering groups, and which is about study is about almost 3,000 of patients with therapeutic mammoplasty, mastectomy and the reconstruction. And this shows us that breast conservation was possible in about 90% of patients who had therapeutic mammoplasty. And this technique also did not delay adjuvant treatments. The conclusion of this is that therapeutic mammoplasty allows high-risk patients who would not be candidates for immediate breast reconstruction to avoid mastectomy in a very safe way. And here you can see some examples, pre-op and post-operative pictures for ladies who had therapeutic mammoplasty. And then different breast size, different ptosis, and still we can offer these ladies different mammoplasty technique with a pleasant result as well. And we have to keep in mind that also unilateral mammoplasty is possible. This is, for example, G.R.E.T.A on the right-hand side to replace the nipple complex. And the therapeutic mammoplasty is possible even with for slightly unfit patients, and this is an alternative, as we said, to mastectomy. Moving on to chest wall perforator flaps, this is a volume replacement technique. We use local flaps of skin and fat based on perforator vessels to fill the defect after while local excision, and this is suitable for small to moderate size breasts. This is a muscle sparing technique. It is completely autologous, and clearly it is less invasive than alternative reconstructive methods. We aim to include small to moderate volume breasts and high tumor to breast volume ratio in breast conserving surgery, and in this way we can decrease mastectomy rate again. We can see now that a chest wall perforator flap can cover defects in north quadrant of the breast. We can use medial intercostal artery perforators, MICAPs, to cover medial defects, anterior intercostal artery perforator ICAPs to cover inferior pole and retroareolar defects, LICAPs, lateral intercostal artery perforator for lateral and central defects, and finally TDAPs, thoracodorsal artery perforator for central to medial defects. And this is the meaning of volume replacement, and we use that for tumor size or location that would cause deformity with standard lumpectomy for patients that are not suitable or don't accept therapeutic mammoplasty, and patients that prefer breast conservation over mastectomy. It is a unilateral surgery and don't require any distant donor site. As we said, chest wall perforated flaps are a valid alternative to mastectomy. I just want to cite the paper of Karakatsanis 2024. He and the team analyzed more than 600 patients undergone chest wall perforated flap surgery, and in about 70% of them, chest wall perforated surgery was offered to avoid mastectomy. In only 1% of these patients, the procedure was converted to mastectomy after the final pathology. The conclusion was that the chest wall perforated flap is a useful option to allow more women to avoid mastectomy, and the procedure is safe and should be offered to suitable patients. And I think we are all in agreement. Here you can see some example, LICAP and LTAP flap. This is the pre-op markings. You can see how the flap volume is measured with height and thickness, and you can see the perforator markings. And this is the post-operative results. You can see the symmetry. We should not have the nipple complex displacement, and also a nice scar on the side. You can see here some ICAP results. And as well, we should not have inframammary fold displacement and the good symmetry. And some other patient with retroareolar and 12 o'clock cancer, pre-op markings, and the final result with a good symmetry and no displacement of IMF fold. Moving on to mastectomy, we know that this is a huge topic as well. As you can see on the right-hand side, the mastectomy rate is still high, is more than 40% in the UK and in Europe, goes up to 80%, for example, in Pakistan. So that is why we have to take this in great consideration. And also we have to remember that immediate breast reconstruction highly improves in patient quality of life. I would like to recall ESSO guidelines. Surgeons should offer the women the choice of breast reconstruction at the time of surgery or afterward. This is not just about aesthetic, because immediate breast reconstruction improves patient overall survival versus simple mastectomy. And we can see here some paper about how reconstruction improves patient quality of life. We know that it restores a sense of wholeness and normality after mastectomy, reduce the negative feelings associated with mastectomy, and gives our patient higher levels of satisfaction with their breast, overall appearance, and surgical outcome versus patients that had only simple mastectomy, and provides our patient long-term benefits for their quality of life. And even if sometimes it requires additional procedures, still a patient that had breast reconstruction recommend it to others in our patient groups. Finally, as we all know, autologous reconstruction leads to higher long-term breast-related and body-related quality of life when compared to implant-based reconstruction, even if both reconstruction offer higher quality of life when compared to mastectomy alone, as you can see on the right-hand side. There are several meta-analyses that have been published in the recent years that highlight how immediate breast reconstruction improve patients' overall survival. I want just to show you one published by Kang that collected more than 80,000 patients with early locally advanced or inflammatory breast cancer associated with autologous, implant, or mixed reconstruction versus simple mastectomy. And the result is that the breast reconstruction group showed a better overall survival when compared to simple mastectomy. That is why we should offer our patient breast reconstruction. There are some indication for mastectomy, and I think we discussed them already when we discussed the breast conserving surgery. So patient in which there is a large tumor to breast size ratio, when there is an inflammatory breast cancer or multicentric breast cancer, previous radiotherapy or contraindication to radiotherapy. We have to discuss mastectomy as an option with patient gene carriers, and finally, as we discussed, patient choice. There are several types of mastectomy: a radical mastectomy, which is today now rare, modified radical mastectomy, simple mastectomy, and finally, skin-sparing mastectomy and nipple-sparing mastectomy when we aim to perform immediate breast reconstruction and we preserve skin and nipple. Nowadays, we have several possibilities of performing breast reconstruction: implant or expander-based, autologous reconstruction, which is considered the gold standard as we aim to replace like with like, which can be a pedicle flap, a free flap, chest wall perforator flap, or total fat grafting reconstruction. And finally, a combination of the above methods, which means autologous and implant or expander. But as we know, no reconstruction can be performed without a optimal mastectomy. And nowadays we aim to have a maximal parenchymal resection, preserving all the uninvolved subcutaneous tissue, minimizing the mastectomy skin flap undermining, and perform as much as possible nipple-sparing mastectomies. We aim for an anatomy-driven, oncologically safe mastectomy. We have to follow the three fascial system, follow the anterior lamella plane, preserve all our perforators, and also the circummammary ligament. There have been several papers published on the flap thickness, and I just will show you one of these. We know that all forms of mastectomy leave residual breast tissue back, but when we perform an anatomical driven mastectomy, there is no statistical correlation between local recurrence and flap thickness. So aiming to a standardized 5 mm flap thickness value is not valid anymore in the current clinical practice, because we do have several methods to manage and understand the optimal mastectomy flap thickness. As you can see here on the left-hand study, there is the Rancati paper. We do have preoperative studies, digital mammograms that can show us what is the flap thickness, and also we have the direct confirmation of the surgical mastectomy plane. We know that there are two main sources of neurovascular supply to the nipple, which are the central and superficial network that provides perforators from second and fourth intercostal spaces, and also the fifth anterior intercostal artery perforator. When we aim for an optimal flap thickness, which might also be 1.5 centimeter when oncologically safe, we can provide our nipple complex an optimal supply on derma, subderma, and subcutaneous plexus. And finally, we know that we can safely preserve our nipple in nipple-sparing mastectomies, offering our patient a superior aesthetic results because we do have a rare nipple involvement mainly related to the CIS. And when we perform prophylactic mastectomies, usually there is no occult nipple involvement. Having said that, I would like to discuss implant-based reconstruction and its evolution from 1980s, when we started with subpectoral breast reconstruction. As you can see on the right-hand side, implant or tissue expanders were placed behind the pectoralis major muscle, and then we had the possibility to perform the so-called dual plane technique, thanks to the introduction of ADMs and synthetic meshes that were used to cover the lower pole of our implants. Shortly after, we were able to move to the prepectoral breast reconstruction technique, which positioned the implant in the same position of the breast, which is a very anatomical reconstruction and allows us to recruit middle and large volume breast to immediate one-step reconstruction. This is a simple technique with low complication rate, and this is what we actually currently use mostly. It allows us to have excellent aesthetic results. The symmetry is achieved in more than 85% of the times. We don't have any dancing breast. The reconstruction is very soft and natural. There is no impairment of the upper limb function, and the postoperative pain is very low. And there are several papers that prove that prepectoral breast reconstruction is very safe and with a low complication rate decreased when compared to subpectoral breast reconstruction. Here you can see some postoperative results. There are different size and shape of breasts. Some patients of these are bilateral, some unilateral. Age is different, comorbidities are different, and I believe a prepectoral breast reconstruction is a safe way to perform implant-based reconstruction nowadays. As we discussed, there are several devices that now are available to perform implant-based reconstruction, mainly divided between synthetic meshes and biological ones. The main aim is to provide mechanical and, in case of biological meshes, also biological contribution to our reconstruction. And there are already several papers that show that the direct-to-implant reconstruction is possible even without any device. And the key point is that we need to have robust mastectomy flaps. So patient selection and good quality mastectomy is mandatory in these cases. Moving on to hybrid breast reconstruction, this is a combination of autologous tissue, which is mainly fat grafting or flap, with implant-based reconstruction. The aim of these techniques is to improve the soft tissue coverage over our implants, to enhance the natural breast contour and feel, and to reduce implant visibility and rippling. Clearly, this has lower complication rate versus implant alone. And the common technique we use is implant and fat grafting or LD flap and implant. We just have to think about revisional surgery, how many times we do perform fat grafting after an implant-based reconstruction. And last but not least, the gold standard for breast reconstruction, autologous reconstruction. The aim is to replace like with like, and I would like to start with Goldilocks mastectomy. This is a technique which is usually overlooked, but it is really handy when we have large ptotic breasts, patients with multiple comorbidities, and these ladies may desire reconstruction but are not suitable for other methods. We have to perform our mastectomies through a wise pattern technique, and we reconstruct the breast mound using mastectomy flap tissue alone. So we don't need any flap or implant. Basically, this is an extreme reduction mammoplasty. It is a simple and one-stage autologous reconstruction, and the complication rate, as we see here, is quite low. And it is really important to keep in mind that if we want to go for a secondary reconstruction, this technique keeps the complication rate really low also for the secondary reconstruction technique. Fat grafting is very common. We can use it to correct contour deformities or as a proper reconstructive technique on its own. As you can see on the right-hand side, we harvest the fat through a liposuction technique, then we process it. Here we see a centrifuge, but you can use whatever you want, and graft in the recipient area. It is an autologous technique. We don't have foreign body reaction. It provides you long-standing natural result and improved tissue viability. Just think about post-radiotherapy treatments. It is safe from an oncological point of view, and it is low cost. There are some drawbacks, which are the unreliable resorption, and clearly you do need to have a donor site. Here you can see the most common indication for fat grafting in oncoplastic breast surgery. It is used for volume restoration and enhancing the symmetry after breast conserving surgery, after mastectomy. You can use it to correct radiotherapy damage, such as fibrosis, poor vascularity, and to revise your reconstruction, implant-based or flap-based, to correct your postoperative complications such as contracture, scarring, fat necrosis, or finally as a proper total breast reconstruction technique as an alternative to implants or flaps. And on this note, it is really handy when you want to reconstruct a full breast mound with a 3D scaffold composed of thin layers of fat. The main indication is small, medium breast ladies. You aim to replace like with like. It is a low-cost procedure, simple, and can be performed as day surgery. You have just to keep in mind that it cannot be one shot only. You need multiple sessions, and you will have an unpredictable resorption rate. There are some complications, fat necrosis, oil cyst, calcification, some donor zone contour deformities. So keep in mind also these drawbacks. LD flap. LD flap is really a nice possibility. Latissimus dorsi is a fast, easy and safe dissection. It has a reliable anatomy. It is a pedicle flap, so you don't need microsurgery for doing it. If you need a skin island to fill any gap, you can raise it in a flexible way. And when you raise this flap, you will not have a significant upper limb functional impairment. You can raise it as a muscular flap only, myocutaneous, or extended flap if you need more volume. Clearly, you can also associate fat grafting in the same setting or as a delayed procedure. And you can do this as immediate procedure or in a post-operative radiotherapy setting. You will have a back scar, but I think this is the drawback of the procedure only. Here you can see some patient markings and some pre-op and post-op results. So usually LD is a nice technique to have in mind. Chestboard perforator flap, we mentioned that for post-lumpectomy defects, but they can be used for total breast reconstruction as well. The indication for this is small to medium-sized breasts. You have to be careful and check your perforators when a previous surgery was performed, especially if you want to go for LTAP or TDAP and the clearance was performed. It is a complete autologous technique. You don't need any distant donor site. You don't need implants. It is a short procedure, can be performed as day surgery, and it provides you a very robust and well-perfused flap. A complication rate is quite low, also in this case, and you can manage this in clinic. You can see here some example. This is LICAP and LTAP flap. This is a LTAP flap only, and this is a TDAP for total breast reconstruction. We should also remember that you can stack a couple of perforator flap if you need more volume. The principle is still the same. You use a perforator flap which fits different areas, and the vascularization is independent. Morbidity for the patient is minimal. They will have a quick recovery, an excellent aesthetic outcome, and the learning curve is fast. And we all know that abdominal flap in breast reconstruction, in particular DIEP, is the gold standard for autologous breast reconstruction. It provides our patient natural appearance, a permanent result. The donor side morbidity is low, and DIEP provides better patient report outcomes when compared to implant-based reconstruction and all the other flap-based reconstruction. It clearly has a longer recovery time when compared to implant, a scar in the donor zone, and there are some patients, the very slim ones, who are not suitable, but is well worth it. You can see here the key steps of the procedure. It uses fat from and skin when we have to perform a delayed procedure from the abdomen, behaves like a normal breast. Clearly, it is a microsurgical breast reconstruction. It is about 6 to 8 hours of surgery, especially if it's bilateral. The in-hospital stay is about 3 days, and the recovery time is 4 to 6 months. The main indication is immediate or delayed breast reconstruction when implant-based reconstruction is failed or for reduced surgery. As we discussed before, very slim patient, previous extensive abdominal surgery or abdominoplasty is a contraindication. BMI over 30 is a relative contraindication, is surgeon dependent. And you can see on the right-hand side the key steps of the surgery. On the left-hand side, you can see the meaning of immediate DIEP reconstruction. We tend to preserve all the breast skin, plus minus the nipple. And on the right-hand side, delayed DIEP reconstruction when we had to replace also the skin with the abdominal skin. Clearly, the preoperative assessment of the perforators is important. We use the CT angio to show the course of the deep inferior epigastric artery and perforators, which can reduce our harvesting time. And also we assess that during the surgery. We also go for assessment of the superficial veins and arteries. And you can see on the left-hand side also the branching within the muscle. This is to see the arterial and the venous drainage before the surgery to optimize our surgical time. Lastly, I would like to show you TAG and PAP flap. These are this is a microsurgical procedure that utilizes tissue from the upper thigh to reconstruct small to medium-sized breasts. And this is a good alternative when we don't have enough abdominal tissue. PAP is a muscle-sparing procedure. It has a slightly longer pedicle with a larger flap and better hidden scar. And the possible cause of this surgery is a loss of sensitivity at the dorsal thigh and a possible donor side complication, but it is a very good procedure as an alternative to abdominal-based flaps. I would like to give you a couple of take-home messages. We nowadays, one size does not fit all. We have to offer our patient tailored surgery and tailored treatments. Training in oncoplastic breast surgery is vital to deliver both excellent oncological safety and aesthetic result, because in surgery, as in patient care, we must never stop learning. And finally, a close collaboration and teamwork between breast and plastic surgeons is key to delivering optimal outcomes for our breast cancer patients. Thank you.
Thank you so much. Thank you so much, Susanna, for such a nice session. And I'm listening and reading the comments here. There are some questions for you. And I think I should take the question. First of all, my question. I'll go start with my question. This is one of the questions that I keep on asking people that how do you manage venous congestion or thrombosis in case of DF flaps? This is one of the most feared complication of in DF flaps for its failure if you have venous congestion or thrombosis.
Well, I think it depends if it's an immediate complication or if it's late. If we spot venous thrombosis in theater, you can do a second vein anastomosis. So this is a good way if it's spotted early, any sign of venous thrombosis, this to perform a second vein is a good point. If it's something which is spotted after the surgery is concluded, I think it's you should take the patient back to theater and to perform re-explore and perform a second vein.
Okay, that's nice. Thank you so much. And everybody can ask questions. They can post a question in the chat box. We have some questions, and I will be asking you some of them. With the names, of course, we have first question from Fiza Khalid. And the question is, which reconstructive technique gives best results in patient requiring adjuvant radiotherapy? Which reconstructive technique gives best results in patients requiring adjuvant chemotherapy?
Chemo, you mean, or radiotherapy? Sorry.
Radiotherapy, sorry,
I
radiotherapy.
think if a patient is going for radiotherapy, we should look for an autologous technique. And if
Absolutely.
the patient has enough tissue, I would counsel her for ADAP or TAGPAB, and anyway for an autologous technique.
Yeah, and that would be a free flap or
If possible,
pedicle flap.
a free flap, but if the patient has enough tissue, also chest wall perforator flap.
Okay, that's good. Then we have another question. First of all, comment for you. It was a wonderful meeting and very informative, very, very informative. A new word for me. Thank you so much by Dr. Tajiba. And she has asked a question. So she has written, madam. So we call you Miss. So Miss Polotto, please guide what is your favorite pocket for implant in case of hybrid reconstruction? What is your favorite pocket for implants?
You mean in terms of ADM or mesh?
In
I
terms
believe
of implant, in case you are doing a hybrid reconstruction.
hybrid. So yeah, I think that if we I usually for hybrid I usually go for implant and fat grafting. So that's what I usually. But in the past I did quite a lot of LD and implant as well. So that's I think that's is quite. This gives us a very good result, and I don't have any. I think, as we discussed before during the presentation, is a good combination of provide the patient a very good soft tissue coverage to the implant, because the drawback of implant-based reconstruction is that, you know, we have rippling, we have issues for the patient feeling the implant edges. And if we look at the literature, about 80% of implant-based reconstruction have fat grafting in the long run. So we have quite a high revision rate, which means fat grafting mostly. So that's an hybrid procedure anyway. So we are,
Yeah.
when we do an implant-based reconstruction, basically we are committed to perform a revisional surgery. At some point, we have to replace the implant. We are performing surgery to young ladies because we are performing cancer surgery to younger and younger patients. So implant replacement is happening at some point. And this usually involves also fat grafting. So that's the key point. When we perform implant, we are going to go hybrid.
That's perfect. Okay, so we have another question that how much fat volume can be grafted in case of fat graft only volume restoration? So if you have to restore volume with fat graft only, how much volume can you use?
So it depends on the volume you have you have in the patient, you know, the volume you can graft on the patient. So it's about if you have the skin only, if you can graft the pack, if you have also LD, you can graft in the how many layers you can graft, if it does make sense, if you have the capsule as well. So it's a bit of a balance, because if you graft too much, you will have complications such as fat necrosis, which is nasty. So you are going to lose your fat grafting. So I think is about, you know, there was, I think you have to be very careful not to graft too much, not to lose all your volume.
Yeah. Okay, so this all is, you have to see the patient and then decide how much volume is
Yes,
required.
absolutely, absolutely, because it is a graft, so it needs to be vascularized in the patient. If you put a big lump of fat, it's going to die.
That is why one of the reasons that only fat grafting is not the solution for complete reconstruction. You have to do it in phases. So,
Yeah, absolutely. That's when you plan a total fat reconstruction, it has to be in multiple sessions. You have to do bit by bit, and to discuss that carefully with the patient. The patient should not have the expectation to be completely reconstructed in one session, because it's going to fail.
yeah, that's true. So we have Demetrius. He's congratulating you for the session.
Thank
And
you.
then we have Dr. Amir again. Thank you for the nice presentation. And he has a question: how to process fat for grafting and how much volume we need to give more, keeping in view the volume loss. So, how much is the volume loss after fat grafting and how to process the fat for grafting?
So the volume loss, if we look to all the paper, it is, you know, variable, but we can say 50-50. If you inject 100 cc, you are going to lose about 50 cc of it. So
Approximately.
we can safely say, tell the patient it's going to be resolved about 50% of it. So we calm down the expectations, our expectation, the patient expectations. So, and I think, you know, if we think about fat grafting, there are so many different way of processing it, and the key thing is the injection technique. I believe that's a main important thing, because all the different methods to process the fat is not going to make a big difference, because if you look how, you know, the viable fat afterwards is more or less the same. The important thing is how you inject it in the patient, and how violent or you are, or how careful you are in the injecting it.
True, true. And again, now we have Dr. Mizan. He's saying, thank you, Ms. Polotto, for a wonderful, informative insight into the current reconstruction techniques in oncological breast surgery. Very useful. Okay, another question from my side. You have been using ADMs a lot. There's a lot of discussion about ADMs, and we have, animal-based ADMs and the other one which are non-animal based. So which one do you prefer?
I prefer ADMs versus synthetic meshes.
Mm-hmm.
I have in my practice, I mainly use the ADMs. I have tried also synthetic. You know, I personally think that the synthetic meshes, you know, they don't integrate in the patient as well as ADMs. That, you know, they integrate nicely. You don't spot an ADM after a couple of months if you go back in the patient, and I don't know, if you put an expander. I rarely use expander, but if you do put an expander, you go back, you don't spot the ADM anymore. The synthetic meshes, you clearly do spot them because they are still there. And I think is a bit opposite to what we would like to have, you know, no extra foreign body in the patient. So if we need to use an additional device, at least something that the patient can integrate in her body. Cannot hear you. I think the mic is off.
Yeah, I was speaking and
Yes.
speaking. Microphone was off. Okay, so I think these are the questions for now, and these are the comments. We have Dimitrios with us. We would request him to come on camera if it's possible for him. He said there's a problem with the camera, but he can use his mic if he has some comments, some things to say. Dimitrios.
Yes, hello.
Hi.
Hi,
Yes, hi,
hi.
how are you?
Great talk. Yep. I would like just to comment on regarding total breast reconstruction with chest wall perforator flaps, which is, I think, a new idea in general. I have tried a couple of times, and thank you, Ms. Polotto, for raising my paper in your presentation. I do have a personal interest in this new technique. I think, as Ms. Polotto said, we need to tailor our surgery on patients' needs. So sometimes, especially in countries where maybe a formal microsurgical setup is not there, I think combined stacked chest wall perforator flaps in women with good skin laxity and ample fat tissue, that they have small to medium breast. I think this is the ideal profile. I think it's a good alternative option either to implants or to free flaps.
Yeah,
And
I totally agree. When I saw your paper, I was really interested. I think is a very good concept, and we do, the patient has, the patient is our tissue bank. Basically, we should look at our patient in their totality, and we should understand what we can use on her to reconstruct. In our case, the breast. And so I totally agree.
yeah, exactly. Yeah. Thank you.
Thank you.
And again, as Ms. Polotto said, that once the patient has an implant, it's always becomes a hybrid surgery because he has to go for, fat grafting and things like this. So one of the complication is capsular contracture. So how do you manage that? How do you tend to manage that? Because once the patient has this disease, this problem, she will, keep on coming back to you for later or sooner, but she will come to you. So how do you manage that, or how do you prevent that?
Well, the prevention is tricky. There are some off-label treatments, such as, you can give her some tablets, but it's very, there are some papers on that, and you can try if you are really concerned that the patient is going to have capsular contracture. Having said that, if the patient comes, there is going to be a degree of the capsular contracture. The issue is that when there is a high degree of capsular contracture, the patient actually comes back to you with that issue. So if it's really bad, and if there is a way to remove the implant and go for autologous, I think it's a good option, because if not, you keep on exchanging the implant, do capsulectomy, and then you have again a capsule, you have again capsular contracture, because there must be a reason why she had a capsular contracture. So it recurs, and then you can try to change the implant, you can try pollute it, and you can try whatever, and it happens again, and the patient comes back, she's not happy. If possible, you can go for an autologous reconstruction, which solves the issues, and everybody's happy. If there is no autologous, you can try and fat graft to soften. This is, it's still an autologous. I think, the patient tissue is a great help to sort out these problems. But still, we all see so many patients coming back and back and back several times for implant revision. So especially, you know, patients that had their surgery at a young age, and then by the time they are 80 or 90, how many surgery did they have? A lot. So
Yeah, that's the thing. So I think we are over the questions. If there are any more comments, anybody from the participants, you can turn your mic on, you can give a comment, you can ask a question, and then if there's nothing, we can just thank Ms. Polotto and of course Dimitrios. Fine. So officially, thank you, Susanna. Thank you, Ms. Polotto. Thank you for coming here and joining us on this platform to teach us and to make people aware about the breast oncoplastic surgical procedures and how they are done and what is their importance and how we can avoid mastectomies and preserve the shape of the breast without having the cancer in the body. So thank you once again. Thank you so much for joining us on our invitation. And we would like to we're looking forward to see you more.
thank you. Thank you for inviting me. It was really a pleasure. Thank you so much.
Thank you once again, and thank you to all the participants who have joined us and asked questions. We will see you again, inshallah. And thank you, Demetrius. Thank you. He's also thanking you.
Thank you. Bye.